Yes.
Or like it's like a non-responsive eye.
Right.
Pretty much. Okay.
Right. So if your eyes are not moving together in concert, then you're going to have double vision. Now, the problem with the disconjugate gaze can either be a muscle problem, one of the extrinsic eye muscles, or a problem with its innervation, 3, 4, 6. So, here we see cranial nerve 3 coming from the midbrain, passing through the superior orbital tissue, and providing innervation to these extrinsic eye muscles. Now let's talk about something very important. The pupillary light reflex. The pupillary light reflex is a brainstem reflex. Brainstem reflex is very important in clinical medicine. Okay? If somebody has a condition, let's say they've been hypotensive, or they have undergone a near drowning event where their brain has been ischemic, not received enough either blood flow or oxygen, the last part of the brain to go is the brainstem. So when we're trying to determine if someone may be brain dead, we test brainstem function. If brainstem function is gone, that person is dead. Okay, because that's the last to go. Okay. In an ischemic or hypoxic event where the brain's not either receiving blood flow and or oxygen. So we test the brainstem reflexes. If you have a patient on a ventilator and you want to determine whether they're brain dead so you can disconnect them, you call a neurologist, and he's going to check brainstem reflexes. And so one of the most important of the brainstem reflexes is the pupillary light reflex. Okay. Now, when we say something's a reflex, it means that the circuit bypasses the cortex. Okay, that the response occurs without volition, without conscious intervention. So, all reflexes have both a sensory and a motor limb. Okay. So let's say this is the reflex center within the brainstem, it would be within the midbrain. Okay. The sensory limb of this pupillary light reflex is carried by cranial nerve 2. It's a light reflex, so cranial nerve 2 receives the light and sends impulses to the pupillary light reflex center in the brainstem. In response to the reception of these incoming impulses, the center triggers efferent impulses carried by 3. And 3 is going to bring about pupillary constriction or meiosis. Okay? So let's suppose that a person comes into the ER, they have suffered head trauma. Well, the physician or the PA is going to shine a light into one of the eyes. The eye into which the light is shined is called the response of that eye is called the direct response. The direct response is the response of the eye into which the light is shined. The response of the other eye is going to be called the consensual response. So if I shine a light into the right eye, a normal reflex reaction would be for both pupils to constrict. It tells me that the right second nerve is intact. In other words, the eye is receiving the light, it's being sensed, and then efferent impulses are being sent down the oculomotor nerve to both eyes. And so it brings about pupillary constriction. Now, let's suppose that the person exhibits a direct response to light, but no consensual response. Where's the problem? Right, not just cranial nerve 3, it would be the left. This is the right eye, this is the left. It would be a left third abnormality, right?
Yeah.
Because we know that the reflex center is receiving light because we have a direct response. The fact that the consensual response is absent means there's a problem with the left third nerve, oculomotor.
So what happens if it were vice versa? Like if the eye that you were shining the light into did not constrict, but the consensual eye did.
Like this.
Yeah.
So where would the problem be in this case?
Cranial nerve 3 of the left eye.
It's always, when I show a drawing, it's always as if the patient is facing you.
Oh, okay, of the right eye.
So this is their right, this is their left, so they would have a right third nerve palsy.
Okay.
Okay? If neither eye underwent constriction, what would that tell you?
That the reflex center was the issue. Or both third nerve.
Or the person has monocular blindness.
That's a lot. It's a lot of ifs.
In other words, if you take a patient who's got monocular blindness and you shine a light into that eye that's blind, they're not going to react. So that's the most common cause.
Okay, so it's the most common.
Okay.
There should be a lot
So that's
of
called the
things.
pupillary light reflex, and we do it whenever someone comes into the ER with any type of head trauma. What's the doctor doing? They're taking a pen light and they're shining light into both eyes to check that reflex response. Okay?
But what if you don't know they're blind? What if you don't know they're blind? Like, what if the trauma is blind?
I'm sorry, so,
You say they come to ER with trauma, right?
right,
But what if they're blind? If you don't know they're blind, or you don't know what happened to them? You understand?
She's asking like,
They were previously blind and they come.
Oh, the
but
trauma
they were
made them
unconscious.
blind.
Yeah,
Yeah.
most of the time when people come in, and this is not all the time, but most of the time there's somebody there that helps you out. That would be an unusual circumstance. But you can figure it out, I'm sure.
Oh.
Okay? Because usually you find evidence on physical exam of cause for blindness.
Okay.
Okay? So for instance, you could shine a light into the pupil and see optic atrophy of the optic nerve on that side. Or you could see a big old dense cataract that's blocking light rays. So usually when they're blind, you can tell on physical exam.
I have a question. So if they're blind and the neurologist is trying to pronounce them brain dead or not, how would they test that?
If they're blind, well, you test because there are other brainstem reflexes. You don't rely on any one. You could have said mustard.
I should have said. We should have tried. I'm sure I'll sneeze again.
Can you contain your
Now,
nostrils?
another reflex involving the third cranial nerve is the accommodation response. When you tell somebody like Victoria, okay, look at that wall, Victoria. Okay? And now what I want you to do is to look at my finger. When she does so, her pupils do this. Okay? That reflex involves the third cranial nerve.
I've been on the wrong page.
Okay. Let's look at this gentleman here. What type of palsy does this gentleman exhibit?
Right,
Left.
left.
This is exactly what's going to be on your quizzes and tests.
Okay.
So
It's the facial one and then the abductive
his
one.
lateral rectus is out here.
Oh.
So what nerve palsy would that be?
Abduct is
If he's got weakness of the left lateral rectus,
Third.
that would be 6. The sixth cranial nerve is called the abducens. It
That's what I was
abducts.
trying
Oh
to
my
say.
God.
Because I was saying the
And
abductive
so-
one.
Yeah.
Without any function of the sixth nerve, then the medial rectus goes unopposed and it pulls the eye in. Because normally there's a balance between the medial and the lateral rectus. If you lose that balance, if you lose the function of the lateral rectus, the eye's going to be drawn in. It's going to abduct. Okay? Now, if I look at this gentleman, I'm going to likely suspect a brainstem problem, an injury to the brainstem or a stroke. Why? Because he's not only got a problem with his sixth nerve, but he's got a problem with the seventh nerve. He's got a left facial droop. look at this, he's got attenuation of the left nasolabial fold. And this mouth here, the corner of his mouth is drooping. If we were to have him here in person, he'd have a little handkerchief or napkin and he'd be dabbing because he'd be drooling as well.
Would he have slurred speech because of that as well?
He could have a little bit of slurred speech. Sometimes they don't. But the idea here is that 6 and 7 are right next to each other. So it would not be unusual for him to have a brainstem stroke that would knock out both 6 and 7. Now, we'll do cranial nerve 5 and then we'll take a break. 5 is the largest. It's called the trigeminal nerve. Of course, it originates from the pons, the rule of force. We said it has 3 divisions, an ophthalmic, a maxillary, and a mandibular. These divisions can be referred to as V1, V2, and V3, with the V representing the Roman numeral 5. Okay? Now, the ophthalmic division exits the cranial cavity through the superior orbital fissure. The maxillary division, foramen rotundum. The mandibular division, foramen ovale. Okay? It's a mixed nerve, mostly sensory, but the mandibular division also has somatic motor fibers to the muscles of mastication. Okay? All right. So this is kind of the dermatomal distribution of V1, V2, and V3. You see that the ophthalmic division feels the upper part of the face and scalp, including the corneas. Whereas V2 provides sensory innervation to the area over the cheeks, the maxillary region. And then V3 provides sensory innervation just anterior to the ear and down to the mandible. Here we see the openings through which these nerves pass. Superior orbital fissure, foramen rotundum, foramen ovale. Okay. Now, remember that emanating from the mandibular division is a branch that enters into the mandible, through the mandibular foramen. What is this branch called?
Inferior
Alveolar. So it provides innervation to the lower teeth. The superior alveolar nerve is actually a branch of the maxillary division. Provides innervation to the upper teeth. Remember at one time we talked about the supraorbital and infraorbital foramina? Well, that supraorbital nerve that passes through is simply a branch of the ophthalmic division. In this slide, we see that the mandibular division also provides innervation to the muscles of mastication. So, Jordan, how many times a day do you masticate?
5.
So you're kind of a chronic masticator.
Yeah, sure.
Then you would be constantly sending impulses down to what muscles?
To what muscles?
What are the muscles of mastication?
The T is the TMJ one.
Well, that's a joint.
Oh, my bad. At least I
You
knew.
tried.
Yeah.
It would be the
The
masseter,
and the temporalis.
temporalis. And then 2 other muscles that we haven't talked about are the medial and lateral pterygoid muscles. But they help us to move the jaw, the
Isn't that a
mandible.
spice?
I don't know.
What?
No, tarragon. That's a spice.
Okay.
I'm sorry, that's just what made me think
Tarragon.
Let's see.
of. He's eating in his teeth and everything.
Can you identify the trigeminal nerve?
Yeah, it's the big one, right under.
You talking about this one up here?
No, the inferior to the eye.
Right here?
Down. There.
Okay, okay. See, I was looking right here.
Oh, that would make more sense because it splits into 3.
Yeah, so this would be the ophthalmic division, this would be the maxillary, and this would be the mandibular. It's moving down through the foramen ovale, and look here, you have a branch that's coming down here into the mandible, That would be the inferior alveolar branch.
That's cool.
Superior alveolar branches, okay, coming off the maxillary division. All right. Let's take a break now.